Well, thank you for the invitation. It's a great pleasure for me to speak in this session with those famous researchers on nutrition in the ICU. Thus, as you know, everybody, when you are sick, you rest in a comfortable sofa, you change your nutrition, you drink and you eat hypocaloric feeding, which are well tolerated by your gut, and also which are in compliance with anorexia, which is a well-known adaptive mechanism, which is part of the acute phase response, with potential beneficial effects such as saving energy, reducing the growth of pathogenic microorganisms, and limiting the potentially detrimental metabolism effects of the acute phase response. The problem is only long-lasting anorexia, which may delay recovery. In the critical care setting, everybody knows that hypocaloric feeding has been associated with increased risk of infection, delayed weaning of mechanical ventilation, and increased mortality. And this is particularly true in severe patients with multi-organ failure. Thus, guidelines recommend to give to the patient 20 to 25 kilocalories per kilo and per day. And guidelines state also that enteral nutrition is the preferred route of feeding over the parenteral route, and because many studies suggest that compared to parenteral nutrition, enteral was associated with reduction in infectious complications, but also non-infectious complications and reduced length of stay. Guidelines state also that enteral nutrition should be started early, within the first 24 to 48 hours following admission. Indeed, enteral nutrition was also associated by all studies, but this was shown also in this meta-analysis with reduced mortality and reduced risk of nosocomial pneumonia. And this was also particularly true in the most severe patients, which will benefit the most from early enteral nutrition. Thus, it is recommended also for patients who have septic shock to give them enteral nutrition as early as possible. However, you know that that those patients with multi-organ failure have also gut failure with paralytic ileus and also delayed gastric emptying, which has been shown in many studies, this reported in many studies, and which is associated with intolerance to enteral nutrition, which may occur in almost 40% of the patients when you consider only vomiting. This was the result of our Nutria 1 study. The problem is that intolerance to enteral feeding was associated with inadequate delivery of enteral nutrition and with low delivery of the calories. So, faced to this situation, we have four strategies that have been studied and reported in the literature. First, to add parenteral nutrition. Second, to use protocol aimed to improve the delivery of enteral nutrition. Third, to provide a little amount of calories via the enteral route, which is trophic feeding. And fourth, to do nothing, to permit hypocaloric feeding. The first strategy, the complemental parenteral nutrition, was studied in the HEPANIC trial and published by Michael Kazer 6 years ago, but failed to demonstrate any benefit of increase of calorie, and in the opposite, demonstrate that late parenteral nutrition was associated with lower duration, length of stay in the ICU and lower rates of infectious complication. Similarly, Gordon Doit, in a study published in JAMA, showed in patients with relative contraindication to early enteral nutrition that adding parenteral nutrition early was not associated with benefit at all, no effect on mortality, infections of length of stay. Studies on protocol to improve enteral nutrition consistently showed that you can increase the delivery of calories. This is quite a constant finding of all this study, but another constant finding is that it is not associated with an effect on the patient's outcome. So the third strategy which was described, reported on studies, the trophic feeding, which consists in giving a very low amount of calories, only 500 kilocalories per day to the patient, with the aim to protect the gut, to give a little amount of calories, so no zero, some calories, to protect the gut from ischemia, on atrophy of the mucosa. But in fact, we don't know the real impact of enteral nutrition. Does enteral nutrition effectively protect the gut against ischemia or precipitate ischemia? We don't know really. And this is why guidelines were and are still very careful for this patient with hemodynamic instability and promote to delay the start of enteral nutrition. So the trophic feeding was evaluated in the study published by Rice in the JAMA, the Eden trial. They included 1,000 patients treated with mechanical ventilation for at least 72 hours for acute lung injury. And patients were randomized in two groups, trophic and standard feeding, with the goal to provide 20 to 25 kilocalories per kilo and per day. The amount of calories delivered during the first week were very different between the two groups. However, there was no impact at all of the calorie amount on ventilator-free days, ICU mortality, and the risk of infection. They follow the patient during 1 year, and there was also no difference between the two trophic feeding and full enteral nutrition for physical and cognitive performance. However, this study has some limitation. First of all, the patient was not very severe, they were quite young, and also the standard feeding group were in fact hypocaloric. They received only 1,400 kilocalories per day. This is probably due to the very complex protocol of enteral feeding and management of the intolerance of enteral nutrition, which include gastric residual volume measurement, for example. So the generality of the study is quite questionable. Last strategy is to do nothing and to permit hypocaloric feeding. This strategy was evaluated in the PERMIT study published by Arabi in the New England Journal of Medicine. They included 894 patients. Almost all of them were treated with mechanical ventilation, but only half of them received vasoactive drugs. And they were randomized in two groups, underfeeding, with the goal to give 40 to 60% of caloric requirements, on standard feeding, with the goal to provide 70 to 100% of the requirements. There was no difference in mortality between both groups, and no difference in other outcome at all. As this meta-analysis recently published by Marek and Hooper included almost all the study on trophic feeding, on permissive feeding, and didn't find any impact of both strategy on hospital-acquired infection, hospital mortality, and hospital length of stay. Currently, the last guideline published in France recommend lower amount of calories per day, 20 to 25, during the acute phase of the illness. On the recent published US guidelines, recommend trophic feeding in ARDS patient and in septic patient. Also, they recommend to withdraw, and that's quite interesting and surprising, to withdraw enteral nutrition for patients who are in unstable hemodynamic state, and which means that they will receive 0 calorie per day, which is quite questionable because it means that during 2 or 3 days they could receive no calories at all. In a study published 2 years ago, we showed that early nutrition, whatever the feeding route, whatever the calorie intake, was associated with reduced mortality, which contrasts with this recommendation. However, one question is, should this strategy in fact be abandoned, not for all the patients, of course, but for the most severe patients? And should we not consider a strategy including very early parenteral feeding at the early phase of critical illness? I leave the next speaker discuss this point, and I invite you to attend the session tomorrow when I will present the data of the Nutria 2 trial. But this is a question. Thus, in conclusion, we could state that the appropriate amount of calories required by severely ill patients during the acute phase remains unknown. There is no difference between trophic feeding and hypocaloric enteral feeding. Normocaloric feeding may be hypocaloric feeding, in fact, at the acute phase of the critical illness. On comparison between trophic feeding and provision of calories amounts as recommended by guidelines is still requested, I think, and maybe by using exclusive parenteral nutrition during the acute phase of the most severely ill patients. Thank you very much.